A very warm hello to everyone. Today we will be discussing about heart failure. Heart failure by definition is a complex clinical syndrome resulting from structural or functional impairment of the ventricular filling or impairment of the ejection of blood, which in turn leads to cardinal clinical symptoms of dyspnea and fatigue along with signs of heart failure, namely edema and raves. Because many times patients don't present with overt signs or symptoms of volume overload, the term heart failure is preferred over the older term congestive heart failure. We have divided mainly the heart failure into three types based basically on the part of the heart involved into left heart failure, right heart failure and biventricular failure. Left heart failure is characterized by a reduction in the left ventricular output, and because of this there is an increase in the left atrial and pulmonary venous pressures. If this left heart failure occurs suddenly, for example because of an acute myocardial infarction episode, there is a rapid increase in the left atrial pressure and causes pulmonary edema. However, when the right atrial pressure increase is gradual, like for example in mitral stenosis, there is reflex pulmonary vasoconstriction in response to this, and this is a protective mechanism against the development of pulmonary edema. However, the resulting increase in pulmonary vascular resistance causes pulmonary hypertension, which in turn impairs right ventricular function gradually. Right heart failure is characterized by a reduction in right ventricular output, and there is an increase in the right atrial and systemic venous pressure. The most common causes of chronic this right heart failure are chronic lung diseases, pulmonary embolism and pulmonary valvular stenotic lesions. The term cor pulmonale is used to describe right heart failure, which is secondary to chronic lung disease. Coming to biventricular failure. In biventricular failure, both sides of the heart are affected, both the ventriculars functions are impaired. This can occur because of some disease processes such as dilated cardiomyopathies or ischemic heart disease, which affect both the ventricles. Also, the disease of left heart leads to chronic elevation of the left atrial pressure, causing pulmonary hypertension over a period of time and then ultimately leading to right heart failure. So ultimately there is biventricular heart failure. Etiologies of the heart failure. Heart failure can be subgrouped as heart failure with reduced ejection fraction when the LV ejection fraction is less than 40%, and into heart failure with preserved ejection fraction wherein the LV ejection fraction is between 40 to 50%. Causes of depressed ejection fraction, heart failure with depressed ejection fraction are coronary artery disease causing myocardial infarction and ischemia. It can result from chronic pressure overloads like as we see in hypertension and obstructive valvular diseases. It can be due to chronic volume overload seen in regurgitant valvular diseases, also seen in intracardiac or extracardiac shunting. Then secondary to chronic lung diseases as we see in cor pulmonale or pulmonary vascular disorders. Then non-ischemic dilated cardiomyopathies resulting from either some familial or genetic disorders or because of some infiltrative disorders, they also can lead to heart failure. Then some toxins and drugs, they can induce damage to the myocardium. In various metabolic disorders and viral illnesses also, the myocardium can get impaired with reduced ejection fraction. Then Chagas disease. Then chronic brady and tachyarrhythmias also can lead to heart failure with reduced ejection fraction. Heart failure with preserved ejection fraction, wherein the ejection fraction is between 40 to 50%. It can be because of pathologic hypertrophies like in primary hypertrophic cardiomyopathies, or can be because of secondary LV hypertrophy due to long-standing hypertension. Also seen in aging, in endomyocardial disorders, in cases of restrictive cardiomyopathies resulting from amyloidosis, sarcoidosis or storage diseases like hemochromatosis, and in myocardial fibrosis. Also, in absence of any obvious primary structural heart disease, there are few high output states where the patient can land up in heart failure. So these are seen in metabolic disorders like thyrotoxicosis, nutritional disorders like beriberi. Then when there is excessive blood flow requirements like there is some systemic arteriovenous shunting, or in cases of chronic anemia, herein we can see high output states where there can be heart failure. For prognostication of heart failure, New York Heart Association has divided the heart failure patients according to their functional capacity into various classes. Class 1 are those patients with cardiac disease but without this disease resulting in limitation of physical activity. So ordinary physical activity does not causes any undue fatigue, palpitation, dyspnea or anginal pain. While in class 2 patients, there is slight limitation of physical activity and they are comfortable at rest, but even ordinary physical activities result in some fatigue, palpitation, dyspnea or anginal pain. In class 3, the patients with cardiac disease have marked limitations of physical activity, and though they are comfortable at rest, but even less than ordinary activity causes the symptoms of fatigue, palpitation, etc. In class 4 patients, there is inability to carry on any physical activity and they are symptomatic even at rest. And any amount of physical activity, the discomfort increases. Coming to pathogenesis. Heart failure occurs when the cardiac output fails to meet the demands of the circulation. Now this cardiac output, as we know, is determined by preload, afterload and myocardial contractility. So preload is the volume and pressure of blood in the ventricles at the end of diastole, while the afterload is determined by the volume and pressure of blood in the ventricles during systole and myocardial contractility. Along with this, on the basis of Stirling's law, as the preload increases, the myocardial contractility also increases. So initially there is increase in cardiac output. So the causes of heart failure are mainly because of either ventricular dysfunction, or there is high output failure in high output states, or because of some valvular diseases. Here there is a diagram where we can show that Stirling's law is depicted. On the y-axis is the cardiac output of performance and the x-axis is preload. We can see that as the preload increases, the cardiac performance is also increasing. These various lines are depicted. A is the normal heart, while gradual deterioration in the myocardial function is there, and D is those patients with most affected myocardium. So we can see, though there is a minimal increase in the cardiac performance with increasing preload, but more or less this curve is flattened. So for the normal heart, as the preload increases, the ventricular performance also goes on increasing. But with those patients where myocardial dysfunction is there, it is not so. So coming to the causes of heart failure, first and the most common cause is ventricular dysfunction. The systolic contraction can be impaired because of myocardial diseases, or there can be diastolic dysfunction, which can be because of abnormal ventricular relaxation, which is either due to a stiff non-compliant ventricle, commonly found in patients with left ventricular hypertrophy as seen in patients of hypertension. Vascular dysfunction reduces the cardiac output, and this in turn activates the sympathetic nervous system and the renin-angiotensin-aldosterone system. In the setting of impaired ventricular function, these consequences of activated sympathetic nervous system and RAS system, they are negative and they lead to an increase in both the afterload as well as the preload, as we can see here in the diagram. So here we are seeing that either there is increased afterload or increased intravascular volume. Both will lead to increased pressure in the ventricles and increase the work. So gradually, when the myocardial loss is there, myocyte loss is there, along with myocardial fibrosis, so ultimately this will result in heart failure. Heart failure resulting in reduced cardiac output, which will activate the neurohumoral system, including the sympathetic nervous system, renin-angiotensin, aldosterone system, vasopressin system, and endothelin system. All this will lead to vasoconstriction and increased sodium and water retention. Again, increasing the afterload and preload respectively. So this is a vicious cycle going on in the patient of heart failure if they are not properly treated. Now coming to high output failure. Sometimes cardiac failure can occur in those patients without any obvious heart diseases. It can be because of a large arteriovenous shunt, or in cases where there is excessive high cardiac output because of very severe anemia, or in cases of thyrotoxicosis. Here also we will find heart failure. The third cause of heart failure is valvular diseases. Heart failure can be because of various valvular diseases, either wherein there is impaired filling of the ventricles because of some stenotic lesions like mitral stenosis or tricuspid stenosis, or there can be obstruction to the ventricular outflow as occurs in aortic stenosis and tricuspid stenosis, and also in hypertrophic cardiomyopathy. Or the heart failure can result because of ventricular overload secondary to regurgitation lesions like MR and AR. Now, clinical manifestations of heart failure. The cardinal manifestations of heart failure, as we know, are dyspnea, exercise intolerance, and fatigue. There are many factors which can precipitate or aggravate the heart failure in pre-existing heart disease patient. For example, an event of myocardial ischemia or infarction, intercurrent illnesses, arrhythmias. Inappropriately, when we reduce the therapy going on, there can be precipitation of the heart failure. Then administration of few drugs like beta blockers, which have a negative inotropic effect, or drugs having fluid retaining properties like NSAIDs and glucocorticoids, they also can precipitate the heart failure. Then cases of pulmonary embolism, condition associated with increased metabolic demands, as we have seen that high output states like pregnancy, thyrotoxicosis, anemia, etc. Then intravenous fluid overload. All these factors are responsible for aggravating heart failure in already diseased patient. Now coming to signs of acute left heart failure. In setting of acute left heart failure, the patient presents with sudden onset of dyspnea at rest, which rapidly progresses to acute respiratory distress, orthopnea, and prostration. The patient may be agitated, pale, clammy, the periphery is cool to the touch, the pulse can be rapid, but sometimes there can be inappropriate bradycardia. BP is usually high because of the sympathetic nervous system activation, but it can be even normal or low if the patient is in cardiogenic shock. GVP is usually elevated, particularly with associated fluid overload or right heart failure. In acute heart failure, there has been no time for ventricular dilatation and the apex is not displaced on physical examination.